On behalf of IPC Partners and Tristel, welcome to this session, which we're pretty excited about, talking about the future of surface disinfection. So my name's John. I'm the Director of IPC at Guy's and St Thomas's in London, and I'm going to hand over to Phil.
Thanks, John. Good morning, everybody. My name's Phil. I am the Manager of Infection Prevention and Control at Oxford University's hospitals, and delighted to be here today. It's great to see the room so busy. If you're new and you've just joined us, please scan the QR code. We're going to have lots of audience interaction via polls. So you can scan the QR code, or you can go to menti.com and put that code in there. But we'll bring that up again for you later on in the session. So just to give you an overview of what we're going to talk a little bit about today, John is going to talk about our introduction and why surface disinfection is so important and crucial to the prevention of transmission and healthcare-associated infections. I'm then going to talk a little bit about what state-of-the-art looks like and what we need to consider when we're choosing our disinfectant. And then John is going to talk more about future perspectives. So what are the challenges that are coming over the hill in healthcare and infection control that we need to be aware of and that we need to be on top of? John.
Okay, thanks. Just conscious of people filtering in. There are a couple of very tightly packed seats at the front. So if you want to come down to the front and wiggle through, please, let's make use of all the seats. Come on in. So I thought this was obviously the natural place to start with a talk about surface disinfection. It is a cauliflower, in case you didn't know. I wanted to start with a study that was published ages ago, 20 years ago, and it was a really innovative study design. What some researchers in America decided to do was say, well, if surface contamination is important, then we ought to be able to track it by using a little piece of cauliflower DNA. So that's exactly what they did. They took a little bit of cauliflower DNA and they inoculated a telephone receiver in a neonatal intensive care unit. And then the study design was to sample the environment and to sample the hands of staff and track the spread of this cauliflower DNA marker throughout the unit. And the results, I think, 20 years later are still spectacular and tell us a lot about the fundamentals of surface contamination and spread. So here we go. This is what they found. So pod D is the pod that they inoculated. 60% of surfaces in that pod were contaminated. That's quite high in and of itself, but the thing that really gets me is look across the unit at the proportion of sites that were contaminated from a single point of inoculation. I think we see something important from this slide too, which shows you how quickly this happened. So if you look at the Z-axis, that's the one going backwards, you can see that within 4 hours, there was significant contamination right across the unit. Any doctors in the house? Look at the MD room, the medical doctor room. 100% contamination. I say no more. So this was a cauliflower DNA marker. This was not a live virus. It was not a bacterium. Clearly, things are a lot more complicated when it comes to transmission dynamics of real live organisms. But I think as a model for transmission and why it's important, this study is really, really key. A number of different studies have been published since then, building on the same method and showing a similar thing, that we have a really dynamic transition between contamination of surfaces and contamination of hands, to the extent that hands are really just another surface that moves around the environment and is not disinfected as often as we'd like. So what does this mean in terms of surface contamination, and how do we make this kind of land, this concept that the surface contamination is important? I think the most powerful idea is this idea of the prior room occupant. So again, some clever researchers theorized and said, if surface contamination is important and you get residual contamination when a patient is discharged, then you ought to see that an incoming occupant to a room that was previously occupied by a patient with MRSA or VRE or C. diff or noro has an increased risk due to that residual contamination. And through a series of epidemiological studies, that's exactly what's been shown. This concept is really important. I think it has far-reaching implications. What happens if people said, well, how was my room disinfected before I was admitted? Which chemical did you use? Which process did you use? And what assurance do you have? What if it was a member of your own family that was admitted to that room? Perhaps your own mother. How would you feel about that? may be different if it was your mother-in-law. Sorry, Lois. And I think to cement this association, there's also really good evidence that if you do a better job of cleaning and disinfection of the surfaces in the room at the point of discharge, this increased risk from the prior room occupant goes away. And that, for me, really kind of lands this idea that surface contamination is a really critical factor in cross-transmission.
Thanks, John. So John's done a really good job there of just illustrating the risk of the environment and the transmission of these organisms. So we're going to start now with a poll. So if you haven't scanned the QR code, you can go to that on Menti now. And we want to know what you're doing in your current organisations. So what is the process that you guys are using when it comes to cleaning and disinfection, or just cleaning of your healthcare environment? If we can shift to Menti. Okay, so we've already had a lot of people vote. Great. Very skewed. Couple more, maybe. Okay, so really interesting. The majority of the people are using combined detergent and disinfectant for cleaning their healthcare environment. That's what we do at Oxford. And then we've got some people in the room who are using detergent and then stepping up the disinfectant in an outbreak situation. Okay, really interesting, but a real clear winner. If we can go back to the presentation, please, thanks. So I'm glad that you didn't vote for detergent, because it's not something that I personally am a big believer in, because there are limitations associated with a detergent-only approach. Detergent doesn't kill microorganisms, it just physically removes them. And there's evidence to suggest that detergent is actually quite good at moving microorganisms around the environment. So if you take a wipe, for example, with detergent only, and you place it on one surface, it'll probably do a really good job of removing those microorganisms. But what happens when you go and clean another piece of equipment with it? You shouldn't, but people do. We know that. People cut corners. And we've now actually seeing more and more evidence that routine disinfection does actually make a difference when it comes to reduction in transmission of some of these infections. And we've just picked out here some of the studies which support the use of routine disinfection and how they can actually make a difference when it comes to keeping our patients and our environment safe. So lots of different technologies used. Some are using extra cleaners, some are using automated systems like ultraviolet light. But ultimately, all of these studies here are giving us really good evidence that routine detergent and disinfection cleaning, or disinfection only, makes a difference when it comes down to the transmission of some of these microorganisms. And my argument for people who are using detergent only is that I don't think we have this level of evidence when it comes to the use of detergent only. So limitations associated with detergent, and then some really good evidence that disinfection does make a difference. So let's think about how we actually decontaminate our healthcare environment. And the purpose of this slide is to show that there are lots of different options available for us. We can use detergents, we can use disinfectants, but is there a sweet spot in combining the two? And I think that the majority of the people in the room agree that that is where the sweet spot is. But then what about the procedure? We've moved away, in my opinion, about the more traditional approaches to cleaning the environment, using buckets and J-cloths, etc. I know we still use that in our domestics, and we do at Oxford, but we rely more on wipes. But we've also got more automated technologies as well. We've got UVC and hydrogen peroxide. So we're just really highlighting that there's a combination and a balance to be had, because we know that these organisms that we're trying to eradicate from the environment, they're really challenging, they're clever, they evolve. So we need to keep on our toes, and we need to think about choosing the right choice for our organisation as well. Every organisation is different. So next poll, if you're already in Menti, then it should have moved forward to the next poll. This time we want to talk about the agents that you use for disinfection in your organisation. So you can choose more than one. So we've got a couple of options there. Good old-fashioned bleach, hydrogen peroxide, peracetic acid, chlorine dioxide, quaternium ammonium compounds, or you can put your own in there as well. So if we can go over to the poll, please. Okay. This is interesting. I love it how it moves around. It's really dynamic, isn't it? Okay, so a big reliance on chlorine. maybe just a little bit of audience interaction. For those of you that put chlorine, can you put your hands up if you use something else on top of chlorine as well, or in combination with? Okay. So mainly just chlorine, yeah. I mean, chlorine is in the national guidance, isn't it? But yeah, a clear winner, some hydrogen peroxide, peracetic acid, a little bit of chlorine dioxide, and some quartz as well. Okay, I'm really happy with how this is working. If we can go back to the deck, please. So when we think about the disinfectants that we use in our organisation, we need to be really clever and switched on, because the organisms that we're trying to remove differ in their susceptibility. So this pyramid here just shows you how, if you're at the bottom of that pyramid, you're actually very susceptible to being killed by disinfectant. But as you move up, you become more difficult to eradicate. And this is why we've got differences in the levels of disinfection that we use. So we might have a more routine disinfectant that we're using all the time, which might be a bit of a lower level. And then we might decide to step up when we've got an outbreak or something like Clostridium difficile or difficile in the environment. And the reason why we have to step up our disinfectant is down to the physiology of the organisms that we're trying to eradicate. The image on the left-hand side, or my left-hand side of the slide, is what a C. diff spore looks like. And that C. diff spore presents lots of challenges when it comes to disinfectants. Lots of disinfectants can't penetrate that outer layer of the spore, which means that it's very difficult for the organisms to be killed by that disinfectant. Some of the more powerful disinfectants that we have at use are more of our oxidizing agents, things like peracetic acid and chlorine dioxide. They're very good at penetrating that outer layer, getting into the spore and eradicating it that way. So the first take home really about what state of the art looks like is that we need to be switched on. We need to think about what we're trying to eradicate and what our situation is, and then choose the appropriate disinfectant for the case. EN standards. I mean, it's a head scratcher, and this just highlights the complexity when it comes to EN standards. And I guess the reason that we put this slide up there here was to say that you need to talk to your manufacturers, your suppliers, about the EN standards that they're using, because these EN standards evolve and they develop over time. So we've just highlighted two here, looking at the sporicidal category, EN 17126, and then a new standard which will be mandatory from May. So sporicidal disinfectant for a wipe or a foam, you'll need to be looking at EN 17846. I got the numbers right, thank goodness. But yeah, EN standards complexity. So different things depending on the level of activity that we're talking about. We have different standards for fungicidal, virucidal, sporicidal. So challenge your manufacturers. Ensure that the EN standards that they are reporting are the ones that are actually relevant to the organism that you're trying to eradicate. When it comes to sporicidal, think about C. diff, think about the structure of the spore, think about that upper level that we need. Some disinfectants won't work against it. So how do we choose the right one? And then I think my final slide is talking about, okay, so how do we build that state-of-the-art disinfectant? What does an ideal surface disinfectant look like? And these are just some of the things that we want to talk about. So we want it ideally to be broad spectrum. We want it to work against lots of different germ groups or bacteria, viruses, funguses, etc. But also we need to be aware that we might need to change our disinfectant if we need to go to that next level. We want the contact times to be realistic, and ideally we want them to be universal. So if we've got a disinfectant which is saying, well, I'm 30 seconds for one virus and 2 minutes for the next, ideally I'd like them all to be uniform. So we know that we're killing everything in that one contact time. And those contact times need to be realistic as well. What's the point of having a 60-minute contact time? Whenever is a surface going to remain wet for 60 minutes? Material compatibility, also a really big thing. We don't want to damage our environment with our disinfectants, so we need to challenge manufacturers on that as well and ensure we have good material compatibility. And also safety. You know, we're trying to move to a more gloves-off culture in the NHS with our sustainability hat on. Do we need PPE for all of our disinfectants? And is there potentially an option to be able to reduce or limit the use of PPE? And if we can't, how do we ensure that our users are safe when it comes to the use of our disinfectants? And again, just highlighting, okay, we've talked about how these organisms differ, but this just gives you an idea of some of the disinfectants that are available and how they fit into those different categories. So just be aware that different disinfectants have different ranges and spectrums of activity, and that actually, when we're considering some of the organisms that are more difficult to eradicate in the environment, that we need to maybe go to the top shelf. We need to go a little bit higher, to ensure that we're getting that higher level of efficacy against things like spores. So choosing things like chlorine dioxide, bleach in some instances at a certain concentration, and just being aware of maybe some of the limitations of some of the lower level stuff, depending on what the task is. And then just some final, we had a lot of evidence in the room from our polls about people using bleach. There's a lot of limitations around bleach working in dirty conditions, and does dirty conditions actually impact with the ability of the disinfectant? This is a really nice study just talking about chlorine dioxide, and you can see here from the chart that chlorine dioxide performs really well against Pseudomonas and Acinetobacter, two organisms that we're really worried about within healthcare. So, look at the comparisons that are out there when it comes to your disinfectants and challenge what you're currently using and think about, is there another alternative out there? I'm going to pass to John.
Okay, thanks, Phil. Anything take you by surprise in those polls? I was expecting to see in the first poll a little bit more in that middle category of detergent only, then step up to disinfectant, because I think that's the closest to what the national recommendations are. So to see that many of you are already using a combined disinfectant detergent all the time is quite interesting, and that's something that we do in my own organisation as well. I definitely think that's the way forward. On the second poll with the various different chemistries, I think it's true that in my organisation I tick every box, thinking about all the different disinfection tasks that we do in the CSSD and surface disinfection. I don't think we have to choose a single agent for all of our disinfection needs. I think we probably have to make a different selection of the chemistry depending on the task at hand. Okay, we want to get out our crystal balls now and think about what's going to happen down the line. What does the future look like in the context of surface disinfection? So let's start with your views. We thought it might be interesting to put a ranking to you as a question and say, which of the following do you consider the biggest challenge to effective surface disinfection? So this is a slightly different poll interface you'll see on your phone there, or your whatever device you're using. You drag and drop the options into the top box, into the right order, and if you do it wrong, it's okay, don't panic, you can shift them around. So you've got 4 options: biofilms, contamination of shared medical equipment, emerging microbial threats, or lack of adequate training and frequency of disinfection. Now, I'm just going to hold fire on going to the live poll because I don't want to influence anybody's choices here. All right, I don't want no bias. I want to have everybody's individual view. So if you haven't yet got your phone out to do the Mentimeter, the QR code is there. When I'm doing training, sometimes I count how many people are in the room and only proceed when everybody's answered. I'm not going to do that today. That would take too long. Okay, anybody want to answer but hasn't had time? All right, let's go live. Let's see what it says. Ooh, that's interesting. I wasn't expecting that. So lack of adequate training and frequency. Somebody was influenced. They changed their mind. Lack of adequate training and frequency of disinfection has come out on top. Emerging microbial threats, contamination of shared medical equipment, and biofilms. What would you have said, Phil?
I would have gone biofilms, personally. Yeah, dry surface biofilm, yeah.
Okay, I think I would have... I don't know what I would have chosen. I should have thought about this beforehand, shouldn't I? I think I would have chosen emerging microbial threats because they're so... The people who chose that are nodding. Yeah. Okay, let's move on. So we're going to... Thank you. We're going to talk about biofilms, just a few words on emerging microbial threats, and then finish on shared medical equipment. As just 3 of these areas that warrant further investigation. We're not going to talk about training and education and making sure the process is done right, which is such a huge area. We could talk all day about that. Just a really prime discussion, and then we want to get over to the Q&A, because I'm really keen to hear what people are thinking about these issues that we hopefully have raised for discussion. So, biofilms. I was involved in a study where we went out and we sampled, we took a whole load of keyboards and other devices out of the clinical environment at the hospitals I was working in, sent them to the lab, and they put them under the electron microscope, and a really, really high proportion of those had dry surface biofilm on. And the big surprise for me was that within those dry surface biofilms was viable MRSA. And we don't see much MRSA in our hospitals, certainly that we know about. So I think this MRSA was sequestered deep within these dry surface biofilms, still viable and still risky. And that was a real important finding for me. So dry surface biofilms could explain why vegetative bacteria survive for so long on surfaces. Amazing study done in the Netherlands quite a few years ago now showed that VRE dried onto a surface in a lab was still viable 4 years after inoculation. This isn't a spore, so it's not a spore-forming organism. There's no reason why the VRE should survive for that long. And yet, through some kind of viable, non-culturable, biofilmy state, it was able to do that. And I think the lesson is, if we don't proactively eradicate these organisms when we need to from surfaces, or at least reduce the level, then they're going to hang around. Time is not going to be our friend. Could also be part of the reason why they're so difficult to get rid of. I'm sure many of us have been involved in studies where you've done sampling before cleaning, sampling after cleaning, and you still find the organism there, even though it's been given a thorough clean. And that's maybe because of this biofilm where there's a proteinaceous matrix that protects these organisms from our efforts to remove them or to kill them. Anybody gone swabbing during an outbreak and you know it's there, you know the organism is there and contributing to the outbreak, and the swabs come back negative? Anyone been there? Yeah, I've been there, and it's really frustrating. And it could be because the organism is there, but it's buried so deep within the biofilm that the swab kind of gives it a little brush, but doesn't get deep enough to actually penetrate and pick up the organisms. So those are some of the reasons why I think biofilms are a really important threat. So I won't go through this table in too much detail, but when we started thinking, Phil and I were talking about, well, what are the key microbial threats? We came up with 4. C. diff is one that we felt we had under control. More recent data suggests that it's increasing again. CPE, these highly antibiotic-resistant gram-negative bacteria, certainly keep me awake at night. Candida auris is an emerging organism, no longer Candida auris, by the way, just a note. And norovirus, not so much of an emerging microbial threat, although it's a topical one when we look at the most recent norovirus season, which is still ongoing. Many more outbreaks of norovirus than we've seen in previous years. And we didn't actually think about the transmission route when we were doing that exercise. So it's quite interesting that those 4 organisms are all predominantly contact spread. Although if anyone was at Yvonne's talk earlier, maybe we need to rethink that with the norovirus and the vomit this way and the vomit that way. Pretty gross. So for all of these organisms, we know that the surfaces around the patient become contaminated, and that surface contamination is a key factor in transmission. And that's part of the way that we're going to address these microbial threats. Just a little example from Candida zyma. If we sample the environment before cleaning and after cleaning, this shows that actually the process they used was effective. But look, think about the cauliflower DNA and how quickly it got from that phone. 4 hours later, the room was recontaminated almost to the pre-cleaning level. So it's a case of painting the 4th bridge and making sure that we're disinfecting at the critical control points in order to reduce transmission risk. So there's some updated guidance from UKHSA around Candida zyma auris, again, kind of pinned on chlorine as a chemistry. My own view is that we need to think beyond sodium hypochlorite and look at other wider options to identify the most effective disinfectant for the task at hand. And of course, all of this feeds into antibiotic resistance, especially something like Candida zyma auris, where the big issue is antifungal resistance, or carbapenemase-producing Enterobacteriaceae, or Enterobacterialis now, where that key issue is resistant to the key agents. And prevention is better than cure, so we need to get a handle of surface disinfection if we have a hope of reversing these trends.
Thanks, John. I think you coined a new word there, biofilmy.
Biofilmy.
Looks a bit biofilmy, doesn't it? I mean, for me, just going back to the polls, it was really interesting to see what people had put. But I think the things that we've highlighted here, there's a common link between them in terms of, we're worried about AMR, but we're worried about AMR in some of these emerging organisms as well. and we're worried about their persistence in the environment. So how do we decontaminate the environment effectively to ensure that we can kind of reduce some of these risks? So I'm just going to close really and say that I think we've painted quite a complex picture when it comes to surface disinfection, and hopefully talked about some of the challenges that there are, but there is light at the end of the tunnel. So this is a recent study, I think the most powerful evidence that we have yet, that cleaning and disinfection of shared medical equipment really does make a difference when it comes to reducing transmission. So this is published out of Australia from Brett Mitchell's group. A randomized controlled trial, so really powerful, really robust, reducing bias in the study design, etc. They put in an additional amount of cleaning, focusing solely on shared medical equipment. So 2 cleaners, dedicated staff, providing 3 hours of additional cleaning of shared medical equipment every week. But they didn't stop there. They did some ongoing feedback and audit, so kind of continuous improvement, kind of quality improvement, to ensure that people were having feedback on how they clean equipment. And I think we've identified this training issue. It's really important that we train our healthcare professionals on how to clean and decontaminate equipment. If you think about a neonatal incubator, think about the complexity of that piece of equipment. How do we kind of clean that thoroughly enough? So the ongoing education and training was really important. And what this first chart here shows you is the dotted line in the middle is the intervention, and they're looking at the thoroughness of the cleaning. So they're using UV markers that you can't see with the naked eye. People were coming in, cleaning it, and they were seeing whether or not those UV markers had been removed. And as you'd expect, after they put the intervention in, the thoroughness, also the removal of those UV markers increased. So the thoroughness of their cleaning actually made a difference on shared medical equipment. But I guess the million-dollar question is, what does this mean for healthcare-associated infections? And they were able to link those results with a nearly 35% reduction in healthcare-associated infections. And I think, we're talking about cleaning, and we're talking about cleaning of shared medical equipment, and our nursing staff and our clinical staff play a vital role in that. But I think we need to focus on our domestics as well. Our domestics do a tremendous job of working and keeping our environment safe. But I think this is the best evidence that we have yet, that there is light at the end of the tunnel, and that cleaning and disinfection does really make a difference. And if we can put that resource into it, that it can make a reduction in infections.